CataractCoach.com podcast series, episode number 76, with Dr. Soosan Jacob, a novel surgical approach to corneal ectasia and keratoconus. Welcome back to our Cataract Coach podcast, and today I have a very special guest, Dr. Soosan Jacob, and you've heard about her very brilliant idea of corneal allogenic intrastromal ring segments for the treatment of keratoconus and other corneal ectasia. So we have so much to ask her, such an innovative thinker. We're going to learn a lot together. Soosan, welcome to our podcast. Thank you.
Thank you. It's such an honor for me to be here. I have been a fan of yours for many, many years, as so many other ophthalmologists are. And it is such an honor to actually be on this show with you. Thank you so much for inviting me. It's a great experience for me.
Oh, you're too kind. But we learned a lot. I just thought the idea that you had was brilliant, because in the past we did corneal ring segments, but these were usually made of PMMA, like the intact or other things. How did you get the idea to use allogenic corneal tissue?
This is allogenic tissue was something I was always interested in. I had started out with the use of allogenic tissue for presbyopia, actually, which is a surgery that I had also started, which I called as PEARL, presbyopic allogenic refractive lenticule. And that the paper for that had actually won the Waring Medal for editorial excellence from Journal of Refractive Surgery, JRS. And that's how I started out with the use of allogenic tissue. But then I, thought that there's such a great use, again, which you can do for keratoconic patients. Because I treat a lot of cornea patients, cataract. Of course, I'm not a pure cornea surgeon. I do a lot of comprehensive ophthalmology. But when I started seeing all these keratoconic patients, like many others, I used to use intacts, Kera rings, all of these things. And I found that after a few years, some of my patients would come back with these corneal melts. And that was something I was always unhappy about. It never made sense that you're doing a treatment and then after some time you're getting the patient back with the complication from the very treatment that you kind of advise them to undergo. And this was something that bothered me. And my experience with PEARL, you just sort of start thinking, right? Okay, you're doing this. Okay, is there some other way that you can use to replace it, still get the effect, but maybe use something else which is not toxic to the cornea or which is not bad for the cornea? And then I just thought, why not allogenic tissue? And now, the first time you think of this, as anyone else who hears about this surgery for the first time, is how do you get it there, right? How do you get it into that thin channel? Because it's very difficult. When you think of corneal tissue, it's just very, squishy tissue. It's very soft tissue. So how do you get it in there? And that was a challenge which I also experienced in the beginning. We tried many different ways. We tried to push it in with curved Sinskis. I tried to kind of pull it in with intacts, type 2 and intacts, and then just thread the intacts in first and pull it in. A lot of different ways, but over the years, we've refined it so much now that, we can do cares in just 2 minutes flat. It's an amazingly beautiful surgery. The patient is very comfortable. It gets over so fast that now you no longer think, it kind of seems absurd now that you are thinking, how will you get this tissue in? So that's about cares. And when we started out, we used donor corneal tissue, but cares, then as the name implies, is basically allogenic tissue of any source. So, it could be corneal tissue, it could be collagen, it could be something else. But because cornea is the most commonly available one, easily available to all surgeons around the world, that's what we started out with.
So let's take it back a little bit. So first you had an idea of a presbyopic treatment using allogenic tissue. So explain that treatment for us in simple terms for a guy like me who's not that smart.
All right. So the presbyopic treatment was, again, when Smile came out, we had bought a Smile machine long ago, the Visumax 500. And we used to get these beautiful myopic lenticules, right? You have this exactly perfectly, the myopic lenticule that you're going to extract,
Right.
its exact dimensions, it down to the microns, and the diameter and everything. So every time you pull out these myopic lenticules and you discard them, you kind of, feel that, okay, this is such a beautiful piece of tissue. Why are you throwing it away? So, then, I had been, presbyopia has always been the bane, right, of ophthalmology, even to the day. It's the,
Sure.
it's the thing that has never found a perfect solution. So that was always in my mind. And I was thinking, I'm just considering different things. And then suddenly I thought, I was also reading up, of course, like all of us do a lot about optics and things like that. And then I thought, and then we had these synthetic, like rainbow implants and all the raindrop implant and all these things. So I was thinking again this along the same lines. If the synthetic implant is there, we all, at least I am very certain that synthetic in the cornea always ends up causing problems with time, and that's what happened with Raindrop, and it had to be recalled. So I was thinking again the same thing. Why not use corneal tissue? Because we've all been doing corneal transplants. Corneal transplant has a history of more than 100 years. The safety is great. The experience with the corneal tissue is tremendous for us ophthalmologists. So I thought, why not use allogenic tissue? And now the problem with allogenic tissue, of course, was how do you get it so precise? And the answer was right there with Smile. You get precisely sized tissue, precise thickness. Of course, you have to wait for the right donor patient, and you have to talk to the patient about the use of the tissue that you're going to take from his cornea. But most patients are quite happy to participate in this procedure. And we would take the size of the lenticule that we wanted and cut it into a very small, with a dermal punch, cut it into a very, very small circular tissue and implant it into the recipient's eye using a pocket. And what this would do is it would make the cornea hypoprolate. So this prolateness that's induced in the cornea would create a spherical aberration, and that would, help the patient to start reading better from here. So,
okay. So let me understand. So you do basically have one patient who has a Smile procedure for treatment of myopia. And so now you have a beautiful piece of cornea and you know the exact dimensions. So then you use that piece of cornea from one patient, use a dermal punch, get a small little central, maybe 1 or 2 millimeter zone?
1 millimeter, 1.5 millimeter, not more.
So you get a 1 millimeter little central part of that cornea and put that cornea tissue into a second patient, a different patient who's presbyopic via a corneal pocket.
Absolutely. That's exactly.
Okay, I get it. And I think you're right. A lot of times we've had history where the cornea doesn't like foreign things in it, whether it's a Raindrop presbyopic inlay, which is no longer available, whether it was the camera inlay we had in the US too, whether even it's some of these intact ring segments, these PMA plastics, maybe if they're thin, they're okay. But as you know, as they get thicker and thicker, the cornea around it gets very upset and angry, and they can even actually cause corneal melts, and they can even extrude. So that's okay. Now I get that. So now explain how do you go from there, and now explain me care. So I have questions. How do you get the tissue? How do you figure out the sizing of the tissue, the thickness, how many clock hours do, where to put it in the mid periphery, how to make the pocket for it, and how to get the tissue into that pocket cleanly?
Okay. So what we do for cares, as I said already, it can be any allogenic tissue, but since donor cornea is the most easily available one, the procedure that I follow is we remove the epithelium from the donor cornea, and then we turn it around and remove all the endothelium. So for removing the epithelium, I mount it on a Baron Hesburg, a Katina artificial anterior chamber, and then remove all the epithelium, turn it upside down, remove all the endothelium. So now you're basically having stroma and the predesmets layer and the Bowman's membrane. That's what you're having. And now, while it's placed, facing up, endothelium facing, not the endothelium, but the predesmets layer facing up, we take a double-bladed trephine. Now, this double-bladed trephine is something. Now, I've been working on care since 2015, Uday. Okay, 2015 is when this idea came, and I started doing it. And then I designed this double. How do you get a concentric cut, right? Because trephines have only single blade. So I designed this double-bladed trephine, and I've also applied a patent for it. And I have a US patent for it, by the way. And that double-bladed trephine is basically two concentric trephines, blades, with which you can cut beautifully, absolutely accurate sized corneal rings. And these trephines are also available in different sizes, so that you can actually get different thicknesses of tissue that you're going to implant. And that is what it is. It's so basically when you're dealing with very early keratoconus, you use trephines which will give you a thin sliver of tissue, a thin ring of tissue. And then when you go to more advanced keratoconus, you use tissue which gives you much more thickness. And now it's not just that. So when we started out, we kind of put these rings on both sides. Then we would do asymmetric rings for asymmetric keratoconus. Just put one similar to Intacs, where you put just one to kind of push the cone up. We did that. But then we soon realized, and in 2018, I started customized cares, which is basically customizing it exquisitely for each patient. So once you start doing customized cares, what you're doing is you're basically analyzing each individual patient's topography region-wise, clock hour-wise, and thickness-wise, refractive error. You take all these into account and you make a plan. And this plan is based a lot on the keratometric data, the elevation data, and all these things. And therefore, it varies from arc to arc. So you can vary the entire arc length. You can also vary the optic zone. Though the optic zone, mostly I keep it around 4.6. There are some types of keratoconus where I move it larger. And you can vary the thickness, regional thickness that is implanted. So where I want more flattening, I would put more tissue, and where I want less flattening, I'll thin out that tissue so that I get less flattening. And then you also have to remember, while you're planning all this, the coupling effect of the cornea, which is that, when you get a flattening on one side, you can also get a steepening on the other side, which you can use beautifully to your advantage to kind of get this regularization of the cornea. The central cornea you can regularize beautifully, so the patient's vision improves, the chromatic aberrations come down, and the quality of vision improves a lot. And you can bring the patient into a place where he can be corrected much better with spherocylindrical glasses, which is one of the problems which keratoconic patients face, because their coma is so high generally that you cannot correct them with just simple glasses. So you actually end up improving their uncorrected visual acuity, their best corrected visual acuity, their aberrations come down, their spherical equivalent comes down, and their quality of vision improves. And also remember, at the same time, you're also kind of increasing the thickness in the peripheral cornea. So what happens with corneas, there's a volume augmentation, and there's also a stretching effect, which redistributes all the stress forces, just as it used to happen with intacts. And this redistribution of stress forces can also act to decrease the progression. So CARES has an effect in regularization, improving vision largely, and to some smaller extent, decreasing progression.
So how are you making, so I understand how you get the tissue and you use your special patented instrument to get the segments that you want. How are you then creating a channel in the patient? Are you using a femtosecond laser in the recipient?
Yes.
Or do you have a mechanical way of doing it?
So we in 95 to 99% of our patients, we are using the femtosecond to create the channel, because we have this femtosecond machine, and our patient clientele can generally afford it. But now we also have patients who cannot afford that, and for those patients, we do use manual dissection as well. So there are manual dissectors, which I've also designed with Epsilon. I have no financial interest in that. And these manual dissectors can be used to create the channels in the patient's cornea. Of course, you have to be much more careful. Jack Parker, actually from US, has done a large series of patients where he uses manual dissectors from AJL. And that's the same manual dissector which could earlier be used for intacts. And these manual dissectors are suction-based, vacuum-based, so you can get very precise. And I've seen he's actually just released a video where he shows how beautifully and how fast he creates a channel. He's just rotated it and it's done. And you can introduce it into that. And actually, I'm actually working now more on these manual dissection techniques for the recipient channel, because there's a large area of the world where femtosecond access is not possible. For example, Africa, it's really difficult. And the incidence of keratoconus, or the prevalence of keratoconus, is high in those areas as well. So what do you do for those patients? Plain cross-linking does not improve their vision adequately. So you just basically end up cross-linking. Their vision remains substandard, and then maybe they progress, and then they go in for a TAL or whatever. So I kind of want to be able to offer the benefit of this treatment even to basically all areas of the world. And that's the reason we are also working on manual dissection of the optic zones that we want. So that's what we have to change: the thickness of the channel that's created manually, the optic zone that's created. And I think if we get a couple of those dissectors, that should be able to make this available in all parts of the world.
So you make a channel then either with a femtosecond laser, or you say like you have a manual dissector, which you can do as well. And then how do you get the ring segment in there, the tissue? Like you said, the cornea is kind of squishy. How are you getting it through there? How do you get it appropriately placed?
So that was kind of, I think, Uday, that was a thought block that I had initially, which all of us have, that, how in the wide world are we going to do this? But what I've realized is that if your cornea is of the correct hydration, now you should not let the cornea get all very hydrated up and, very soggy, because the cornea absorbs water, especially when you remove the epithelium and the endothelium. What happens is it starts to absorb whatever it is put in. And then it becomes very thick, and, it becomes kind of not very, its handleability decreases. You cannot handle it as well. It kind of starts to slip from your hands, and you cannot really hold it well. And when that happens, it's difficult. So what I do is I remove the epithelium, endothelium, cut out the punch, customize it, which I have a CARES customizer for that. It's a simple instrument. I use that to customize the segment, and I keep the segment aside. Now I move to the patient, quickly create a femtosecond channel, and by the time my segment it's no longer very soggy. It's dried out a bit, but it's not very dry out either. And I can just put that there, and insert it using a curved Y. So, the same, there's a Y rod that we used to use for cataract surgeries. There's a reverse Insky that we use for DMEX and PDEX. And I just took those instruments and just gave them a curve so that they go around these channels. And I used a curved Y basically to push it from one side. And I used a curved reverse Insky to pull it in from the other side. And that's basically how you can do it. Now, that's how I do it. Jack Parker and Shadi Awad, both from Shadi from Lebanon and Jack from US, of course, have described the dehydration technique, where what they do is they leave it out for an extended period of time, maybe half an hour, 40 minutes, and that dehydrates it. And then it actually looks like plastic. It feels like plastic. It behaves like plastic. You can actually hold it and it becomes stiff, and you can just thread it in. That's really a beautiful way to do it as well.
Oh, yeah, so I get it. You dry it out for 30 minutes or so, and the cornea becomes a lot more rigid.
Well, I don't do that because I don't want to wait for 30 minutes or 40 minutes. And I just do it the way I told you. I cut it, I make the channel, and I'm done. And it doesn't take me more than maybe 30 to 40 seconds to insert it. It's fast enough for me. But if you want to, and maybe if you're beginning, you're doing your first cases, you could also do it this way, and it becomes really easy to.
And what have the results been so far? I'm sure you've done this for a lot of patients. The results have been pretty promising, right?
We have 800 plus patients.
800, wow.
Yeah. So the COVID brought our numbers down, because for almost 2 years our numbers were very low. Otherwise, I think we would have been much higher by now. But we do a large number of cases. Almost every day we do a couple of cases at our hospital, and our numbers very good. The results are really good. And it's not just me who's showing these results, but now if you go online and you search about CARES, you see that there are so many other authors in peer-reviewed literature from around the world who are showing their results and showing such promising results with the improvement in best and uncorrected vision, and decrease in aberrations and all that. So CARES really does do make a lot of difference in the patient's life, and you have to understand why. When you're putting a plastic segment, you're limited by the amount of thickness that you can give to the plastic segment, right?
Correct.
You cannot. And these patients have already got thin corneas. They're already thin. And the ones where you want maximum improvement are the ones who are the thinnest. And those are the people who require the thickest segments, right? And they're the ones who are likely to kind of melt out. And another thing we have to remember is these patients have a tendency to rub their eyes, right? And if you have plastic and when you did the surgery, you might start off thinking, okay, this guy's got adequate thickness. I'm going to be safe with him. But then there's some progression, or he keeps constantly rubbing his eyes. And what you originally thought was thick enough has now thinned down. So it's no longer thick enough to protect the cornea above it. And then it just melts. And remember, it's not just extrusion that's been reported. Intrusion has also been reported in literature. It goes into AC. It goes into the anterior chamber, and there have been cases of hydrops, acute hydrops, which have been reported after intact or CARES. And sometimes it doesn't go into hydrops, but it just kind of causes a small bit of fibrosis, but it's actually jutting into the anterior chamber. So all of these have been described, and Shadi's just published where he's used a CARES to treat an intrusion into the anterior chamber. And I've got a series where I've treated extrusions of intacts with CARES, which means I basically remove them and replace it with CARES. That's the defect that's created. So yeah, you can use it for a large number of situations. You can use it to treat intacts. I've used it for a patient who had post-intact pain, because sometimes intacts is a hard thing and it goes and presses on a nerve. And this patient can have constant pain, and vision is not improving enough. He's not satisfied with his vision. I've removed the old intacts and put in a new CARES, made a new channel, more superficial, and inserted more amount of tissue, which flattens out the cornea.
Wow. So now you have colleagues. You're saying Jack Parker here in the US, Shadi Awad in Lebanon. So you have a lot of colleagues here who are kind of also contributing.
Many others. I'm really happy to say, Uday, that now it's being done in more than 35 countries around the world. And in each country, number of multiple centers. It's not just one center in one country. I think US, there must be at least 7 or 8 centers which are doing CARES. And all around, everywhere it's being done by a large number of doctors. And we have patients who are so aware of CARES now, they come in asking for CARES.
Wow.
Yeah, so that's I think the word of mouth is going around in the patient community, because keratoconus patients they all have these support groups where they talk about what's happening and things like that. So we have a lot of patients also who come in to inquire.
Wow, fantastic. Well, I love the innovative thinking there. Some of our listeners and viewers may not realize that you're also an accomplished orbital surgeon, oculoplastic surgeon. Like the first thing I heard of you was many years ago, you had a very innovative way of doing like a frontalis sling with just a single stab. Tell us about that.
Okay, well, that was my first innovation. That is what I claim. That made me so happy because it was the first time I did something that was not from a textbook, but something that I was thinking, oh my God, I'm going to put three incisions on either side, which is six incisions on the small little boy's forehead. And he's got these droopy eyes. I make them all right, but then I give him these horrible scars over here. What can I do to prevent that? And then it
Right.
just stepped into my mind, why would you want to take it out? Why do you want to kind of bring this needle out, the slings, the steel needle out and then take it again? You can just turn its path. And it was a very simple concept, just don't take it out, but just move it or reroute the path so that it comes out only through a single central incision. But that made me so happy because it was the first time I did something of my own, which was not written anywhere. And that was like years ago. Yeah, that was the very first time. But yes, you're right. I did an observership in US for about 5 to 6 months in 2005. And at that time, there were not many fellowships in India. So this was how I got trained. I did my training sort of just by observing oculoplasty. I came back and I started doing oculoplasty surgeries. I did orbitotomies. In fact, on my YouTube channel, I have my orbitotomy videos, blowout fractures, and all that. So I was quite a bit of a comprehensive ophthalmologist, doing a lot of glaucoma, and I still do glaucoma, cataracts, drop diodes. Retina just related to intraocular lenses, cataracts basically, drop nuclei, drop cataract, IOLs, and things like that. But I have kind of cut back on my oculoplasty and orbit because there's just basically no time for it now.
Well, that's an amazing skill set. I'm just thinking, like, I don't know any cataract surgeon in the US who will do all cataracts, all corneal surgery, all glaucoma surgery, vitrectomy, first plane of vitrectomy or drop nucleus, dropped IOL. You'll do oculoplasty and orbital surgery. There's no, what's left? That's amazing. It blows my mind.
I don't do peels. I don't do peels. I don't do hard.
Oh, no strabismus, no squint.
No, I do strabismus. I've done muscle
You do
transpositions
strabismus too.
Of course, I used to do it a lot. Muscle transpositions, everything. I used to do it a lot. But all that is now cut off because I don't have time. I focus now mostly on cataracts, cornea, complex anterior segment reconstructions, glaucoma, and stuff like that. But I used to do that a lot, and I used to enjoy doing it. Those were good days. And Uday, I think I really think that all of us, need to kind of know a little bit of other things as well. For example,
Yeah.
and now it's coming into ophthalmology, like middle segment surgery. That's the name given to pars plana vitrectomy, as far as the amount that an anterior segment surgeon should be able to do. And I think that's an important skill set. I think a lot of people are now focusing their training on kind of also including that into their training so that they're able to do a little bit of, you have a posterior capsular rent, you have a dislocated nuclear IOL, you should be able to kind of handle that without having to call in the retina surgeon. I'm not saying you have to. If you don't feel comfortable, don't. That's of course a given. But if you can train yourself to do those as well, I think it's a great skill to have.
Yeah, it sounds. I mean, it's a very wide and broad skill set, which I think is fantastic. I mean, for a complex anterior segments case, certainly being able to do at least a pars plana anterior vitrectomy is super important. Now, you also did a very innovative case once that I read about, which was like anterior segment like transplantation. Tell me about that. I was like, I would never even think of this.
All right. So yeah, anti-segment transplantation. So we had Dr. Amar had started doing the glued intraocular lens in 2007, and we were doing a lot of glued IOLs. And then we had this child who came with a huge anterior staphyloma. The child was advised, evisceration and a ball implant just for cosmetic purpose. But what I thought was a large conjunctival graft could solve the problem, but it wouldn't solve the problem fully because you're losing the iris, right? It's an anterior staphyloma.
Right.
The iris is completely gone. So you need to put in an iridia IOL, but then it's the amount that you're cutting out is so large that the aniridial is not going to fit into the rest of the sclera. So what I thought is, and you're taking a large conjunctival graft just to fill the defect. So the large conjunctival graft actually has space to create two flaps on either side.
Okay.
So what I thought is, why not do a glued intraocular lens on this conjunctival graft, glued aniridia intraocular lens on this conjunctival graft, and transpose that entire cornea, sclera, intraocular lens, the artificial iris in the form of the aniridia IOL, you have the trabecular meshwork, you have the anterior chamber. So that kind of is, the anterior segment of the eye. And so we transplant, fix this aniridiol on the donor cornea, remove this patient's anterior staphyloma, which is a large area of the eye, and then transplanted this whole thing en bloc and just did the suturing. And that
Wow.
is like basically an anti-segment transplantation. And of course, now in US, whole eye transplantation was recently reported along with the face transplantation. I'm not sure how those results are, but of course, but these are I think these now when you do a large corneal graft, there's always a chance of rejection and things like that. But the good thing is you created a base for yourself. So even if there's a rejection from the large size of the graft, you still have a good base. You have the anatomy that's restored. The iris is there, artificial iris is there, so you can still do a DMEC or a pre-Descemet's endothelial keratoplasty or whatever, and you can still keep fighting for the vision of that child.
But wow, so how do you reconnect like trabecular meshwork to collector channels? How do you do that?
It's not going to. But remember, the glaucoma may not be a big issue in these patients because when you're doing all this, you somehow inadvertently will be creating cyclodialysis clefts here and there.
Right.
So post-operatively, the pressure may not be as high. And if it does increase, then you might have to do an AGV. But what I'm saying is the why we named it anterior segment transplantation was because all these structures were there. That's the
Right.
reason we called it that. I'm not saying that the trap was functional.
No, of course. So
Yeah.
how did the patient do?
The patient did very well. We could see his optic nerve on the first day with the indirect, the child. We had a beautiful optic nerve. We did a visually evoked potential, which showed very good response. The patient named his child after someone in the hospital, which was great. The parents were very happy. But over time, the graft did reject. But the good thing is the child had a deformed looking eye, which was cosmetically very unacceptable initially to the parents. And not only was it cosmetically unacceptable, it was so protruding that the child couldn't close the eyes at night. And the whole cornea had got exposed, and there were excoriations on the cornea, which was causing pain to the child and a lot of other problems. All of that was fixed, and cosmetically the size of the globe was maintained, which allowed the face to, the orbital bones to grow well, and there was the facial asymmetry and the bony asymmetry did not develop in that child because of that. So cosmetically, he looked great. And as I said, the parents did not come for follow-up for long. I mean, the graft kind of opacified, but and the parents did not want to keep on undergoing surgeries. But remember, because we've created a base, and if the parents were willing for it, we could have done another pre-Descemet's endothelial keratoplasty or a Descemet's membrane or even a DSEC or something like that to clear it up. Or even a repeat graft, a smaller graft in the larger base that you've created, a repeat penetrating keratoplasty.
Yeah, but I think you're right. The before and after is so huge. With such a huge anterior segment staphyloma protruding from the globe, can't close the eyelids, to basically, though may not be a very great functional visual eye, it's functionally, it keeps the orbit open, allows facial bones to develop normally, has a much better cosmesis. So there's certainly some upside there. Well, innovative thinking, things I would have never thought about. Now tell me.
Say, Uday, at this time is that sometimes some of these things that you do may not give you the results in your hand, but it's documented there, and you've kind of let people know that such a thing is possible, and someone else might build on this further and do something that gives you functional vision also at a later time. So that's how all of ophthalmology develops, right? You don't get the perfect result or the perfect answer with one thing. You keep developing further and further on someone else's work. Someone else has done something and you think one step further, and then someone else thinks another step further, and someone else thinks one more step further. And that's how you finally reach that beautiful end point, which we are all looking for, which is a great, anatomically great eye and functional vision.
Right. It's an incremental thing with our colleagues. We all together kind of each take steps forwards as a group. So a lot of contributors. That makes a ton of sense. Now, tell me, what is something new you're working on? You're a mind like yours is brilliant. You must be working on other projects too in ophthalmology.
I am actually. Currently, what I'm concentrating most on is custom shaped cares, which means that we are not just keeping it as arcs, but we're giving it custom shapes, which is going to kind of improve the results more and more. We're also now working on very mild and early keratoconic patients where we use cares. And we are working to kind of finely titrate that so that we are able to get the results we want. So those are the newer things that we're doing. In addition to that, I'm also working a lot on iridoplasty and pupiloplasty techniques, and hopefully we'll be able to come up with something soon. Let's see, that's a work in progress. And then, just basically basically complex stuff, complex anterior segment reconstruction. That's my passion. I love doing that, and I think that's something that excites me a lot.
Yeah, let's go back to doing presbyopia treatment. Now that I'm a presbyope, I'm very concerned with treatment of presbyopia. That's obviously a very important thing too. So maybe that'll progress further. But I do like the idea of using allogenic tissue, which just makes so
Right.
much more sense because we know we've seen over many years the cornea just gets mad when you
Mhm.
put plastic in it. It doesn't want plastic ever.
Absolutely, absolutely. I think the only place in the eye which actually takes plastic is the capsular bag. And
Right.
that's the artificial lens, That's the only place where it sits healthily and happily for years and years on end. And anywhere else in the eye, it is not the ideal place.
Yeah, no, for sure. Now, where do you think ophthalmology is going to be or anterior segment surgery is going to be in 10 years and 20 years? If you looked in your crystal ball, what do you think it's going to come to? Are we going to have more robotic assisted, more AI stuff? Are we going to have a remote ability to do full diagnosis without even seeing a patient in person? What's
For
coming?
sure,
What do you think?
I think that's all going to come, and I don't know how soon it's going to come, Uday. But the way things go, how the way things move exponentially rather than step by step in all of the world today. Because of the way computers are advancing everything. For sure, robotic is going to go more. It's not going to replace the surgeon. I don't think that's going to happen because you still need to kind of there are a lot of fine steps in ophthalmology, I think, which really need a surgeon's hand. And then AI is going to take a large role in IOL power calculations and whatnot, maybe a sulcus to sulcus diameters for phakic IOLs and all these things. I think AI is going to play a large role, retinal diseases and all that. Um, um, and post-operative analysis, I think, of patients is also going to be highly AI dependent. Pre-operative diagnostics. Also, there are already so many other newer devices which are in the market where I don't remember the name of the company which manufactures it, but you can actually show the patient how each intraocular lens looks like, what the
Hmm.
vision will be like through different kinds of intraocular lenses. You also have these there's another machine which the patient can actually wear it and spend a day and it gives a sense of what is their visual needs or the visual needs of that particular patient. Is he more far dependent, more intermediate dependent, or more near work heavy? So that gives a good ability for the surgeon to kind of decide which kind of lens to go for. The other thing is I think sensors within the eye will also probably
Hmm.
progress. Where you can, and we know already that Google's doing a lot of work on that. Maybe contact lens, based sensors or whatever. The thing I like about the eye, Uday, and if you thought about it, is we have so many different kinds of surgeons, right? You have abdominal surgeons, general surgeons, ophthalmic surgeons, ENT surgeons. Have you ever noticed the one thing that sets us apart from all the other surgeons is that you can see what you've done, or you obviously you're seeing what you're doing, but you can also see what you've done forever, right? You see
Right.
your operating field always. Whenever the patient comes back, you have their operating field right there in front of you, and okay, this is what I did, and this is how it's scarred, or this is how it's fibrosed, or this is the way it still remains clear. And which other field has the ability to do that without using maybe fiber optics or doing a scopy or something like that? We have this beautiful place, and I think that gives us a lot of ability to make decisions preoperatively about our next set of patients. Okay, so that's how this happened, and so this is how we should change our things, whatever we do for this patient. That I think is one beauty of ophthalmic surgery, which really, it's other than of course the finesse in it, the submicron or the micron level, all of that, but this is another beautiful thing.
Yeah, I mean, given the anatomy, it's so easy for us to see post-op. Again, like you said, the whole surgical field. Like when I do a cataract surgery, post-op, I can see dilate the pupil. That's my exact surgical field again. Orthopedics or brain surgery, abdominal surgery,
Absolutely.
you don't have that ability at all. It's all blocked
Absolutely.
up
So
inside.
all of them, when you have a complication, they're wondering what's happening. What exactly is happening inside, and they're forced to
Right.
take the help of MRIs or CT scans or some kind of a scopy or a fiber optic or something. And all we have to do is just put the patient on the slit lamp and look, and we see.
That's true. Now that begs the question. So could you operate, let's say doing IOL surgery on a patient, and just get all the data done remote. So you can get anterior segment photos of the patient. You can get anterior segment, posterior segment OCT. You can get obviously wide angle imaging of the entire retina. You get all the biometry done. You get your topography, your high order aberrations, your auto
Absolutely.
refraction.
It's a complete suite. It's a complete suite of all the diagnostics, right? And I think there are already machines and companies which are working on this. At our own Agarwal's Eye Hospital, we have the machine called, we have a machine which has combined the anterior segment OCT and the posterior segment OCT so that you can actually see the entire eye. So you're not seeing section after section separately.
Right.
So you're not seeing an ASOCT separately
Right.
and then seeing only the retina part separately, but you actually see an OCT of the entire eye, which gives you axial length and everything, So and that added to that, I'm sure it's not going to be difficult to add a topography to it or nebrometry to it. So you could really do this. So all you have is this one machine, and the patient goes and maybe leans against it, and you have this one snapshot taken, and that's it. You have everything there.
Get that one exam done. You don't even have to be there in person. You can examine the data. Even better, AI can go through the data, give you suggested lens power, surgical technique. AI, then you send the data to the robot who's going to assist you, right? Then you do the surgery. And
That's
it's just like
a good futuristic view, but definitely it's likely to happen. It's definitely likely to happen. Though I still like the old-fashioned use of my hands.
No, of course we all do. I don't think robots are going to take away from our surgery. They're going to assist it. So, it's like when you see now for a cataract surgery, the femtosecond laser assists you.
Absolutely.
Or even for your CARES technique, the laser is an assist for you to do this, but you still need the surgeon. Well, when you fly anywhere, there's a pilot, even though the plane has autopilot, right?
Very true. Well said. That's very correctly said, Uday.
Absolutely. So I think it'll be good for us. I think we'll have nice new technologies. It'll hopefully make our lives easier.
I hope
Just think back to the old days, how you had to measure a patient, sit there where the people may not know, young ophthalmologists may not know. There's this device in your clinic for these young ophthalmologists when you're in the county hospital, the VA hospital. It's called a manual keratometer. It looks like a black telescope, has these two dials on it.
I know. And you have all the small crosses and the circles, and you have to align all those things. I know.
I bet most young ophthalmologists don't even know about this machine. But listen, when I first started residency, we had to measure the Ks with that.
Absolutely.
Then you're doing an A-scan ultrasound. If it's applanation, hopefully you're not indenting the cornea. Maybe you're going to do immersion. It was so different. It's so wild to think where we've come.
Sure. Yeah, wow. But I'm sure AI is going to play a large role, a huge role. And with the amount of data also there, that's increasing in the amount of data that you're getting, right? So, for example, coming back to keratoconus, earlier the incidence of keratoconus was thought to be much lower, but now it's thought to be as high as 1 in 50 patients. 1 in 100 patients. That's humongous. Right. That's like if you go to a classroom of students, you've got at least one child who's got keratoconus there, right? So right. That's also happening because your diagnostics have got so much better. You're able to pick up these cases early, and previously there would be, you would have missed so many patients. Some of them would have had keratoconus, would not have progressed, they would have struggled, but they would never have been diagnosed, and they're just going through life, with some suboptimal vision, but still managing. Now your diagnostics have become so much better, and also patient awareness is so much better, and their demand or their need for clearer vision is also higher. And we're also able to offer them better options than they were earlier. Earlier there weren't much options for treatment, but now we're able to do so much more that it's really nice for both the patient and the doctor to be able to do this.
So now with our newer diagnostic devices, we can diagnose KC or keratoconus earlier. That begs the question: should we then do a surgical treatment earlier? Because right now the old dogma thinking is, well, no, put them in hard contacts while keratoconus is mild or moderate, and then reserve surgery for severe. But maybe it makes more sense to do a very small amount of cares at an earlier stage.
Absolutely. So I absolutely am against this idea of giving contact lenses alone, because what happens is contact lenses can give beautiful vision to the patient. They see so well. They're so thrilled with the quality of vision which they've never experienced throughout their life. And they go back very happy. But then the disease keeps progressing, because it's a progressive disease and we've not done anything for that. And then they come back later with a progress disease. So especially in children, I'm very aggressive because children can progress much faster than adults. And for children, I do not wait to document progression. I go ahead straight. And if they require a CARES, I'll do a CARES. Now that we're doing it in more early cases, many of the patients do undergo a CARES as well. And surprisingly, children can cooperate very well under the femtosecond to create the channels. So
And what's the youngest age?
8. My
8?
youngest CARES patient's age is 8 years.
Wow. And an 8-year-old will cooperate with the femtosecond laser?
Absolutely. Absolutely. And I'll tell you a very simple test that you can do in your outpatient
Tell
department
me.
to see if the patient will cooperate. And that is, you just go and touch the patient's conjunctiva there, okay? Just do that. And if the child doesn't kind of...
For the people who are listening on the podcast and don't see the video, she's basically using her fingertip to gently touch, let's say, the temporal conjunctiva of the eye. And if the patient tolerates that, then it's easy.
It's easy. That child will definitely cooperate with you for again. But if the child's kind of very reactive and draws back and is scared, then he may not. And most children will. And we just talk them through it. We kind of tell them, we show them, look, this is how much pressure you will feel. A little, we just touch them gently on the shoulder. There's not going to be any pain. You may feel a little bit of touch sensation. Look at the green light and all that stuff. And they're generally able to do it. I've got a series of about 55 to 60 patients, less than 15 years of age, whom we've done CARES on. So we've got a sizable pediatric population. And I am, as I said, more aggressive in the childhood because they are the ones who are likely to progress much faster. So I always treat them.
Wow. Now, the other side of the equation is, how do you prevent eye rubbing in a child? These are the chronic eye rubbers, right?
Scaring them. That's the only way. You have to tell them that, you're going to rub your eyes, it's going to get worse, and, you'll end up requiring more procedures. So please don't rub your eye. Please don't rub your eye. And you need to keep on saying it at every single visit. And you have to keep on telling the parents also, because it's a big responsibility on the parents to make sure that the child is not rubbing. And although it's not just the eye rubbing that I talk to them about, it's like any pressure of any kind. So it's not nice also, or it can also add on to progression if the patient's sleeping face down with the pressure from the pillow, or maybe keeping their eyes resting on their arm and sleeping. That should be avoided. Similarly, sleeping face up, but then again resting their arm on their eye, that should be avoided. Any kind of mechanical pressure on these patients should be avoided. And especially because I also do a large number of DALCs also, since our referral centers gets all kinds of advanced cases. You can actually see on these patients how soft it is when you're doing a DALC. The cornea is just abnormally soft. It's abnormal. And especially in the intratemporal quadrant, you can actually make out the difference when you touch the cornea from between the supranasal and the intratemporal quadrant. It's so palpably different. And that's the reason these patients progress so much. And that's the reason eye rubbing just makes it far worse.
So does cross-linking have a role in this? Or are you doing exclusively CARES?
No, cross-linking. It's always with cross-linking. Because CARES does contribute to decrease in progression, but by no means as much as cross-linking would. Cross-linking is the most important technique to decrease and, if possible, prevent progression completely. CARES has a contributory role, but CARES' major purpose is to improve vision, and cross-linking's major purpose is to decrease progression, and that's why they both act synergistically.
So in what order do you do it? You do
I do CARES, yes. I do CARES first, and immediately I cross-link. So it's CARES and cross-linking, and the patient comes out having both. Same day, absolutely, same day. The patient comes out having done both surgeries. So their epithelium, I always do an epi-off. The epithelium's healed by about the 4th or 5th day. Many patients want the next eye immediately. If they want it immediately, I do it. Some patients, because you do need about 1.5 to 2 months to be able to give them glasses. So if it's somebody very active, they want to be able to use the other eye for continuing to work, then I give them that 2-month gap and I tell them, okay, once you're comfortable and we have given you glasses for the just operated eye, we'll do your eye at that time. But there are also many patients who just want to get both eyes done at the same time and finish it off.
Oh, so you do bilateral even, or you still do sequential?
Not on the same day. Not bilateral on the same day, but different days. No, I don't do bilateral simultaneous.
Well, what do you think about bilateral simultaneous, let's say, just routine cataract surgery? Is that reasonable?
Well, I think provided all the precautions are followed, everything that's there, then it is reasonable, considering that, there might be some patients who are very far away. It's difficult to bring them for follow-ups. Let's say a patient who's had a stroke it's really, really difficult to get them very old patient and things like that. Yeah, it is reasonable in some cases. But I am not that aggressive. I generally, space it by maybe even 1 or 2 days if the patient really wants it early. But if it really makes a difference in the life of the patient and you followed all the precautions, I'm not totally against it.
Right. No, I agree with you. Especially if you treat each eye as a separate patient.
Absolutely.
Do one surgery complete, finish it, new instruments, new everything. And second eye is actually treated as if the second eye is a different patient.
Yeah.
I think it's really not much of an issue.
Yes.
At least that's what some of the studies have shown. But no,
And also remember the batch numbers of the medicines also have to be different.
right.
All the batch numbers have to be different because you don't want to have that one contaminated batch in both eyes.
No, that's for sure. That's a great point.
Yeah.
Tell us, obviously, we've learned so much about all your brilliance in ophthalmology. What else? What do you do for fun? What do you do outside of ophthalmology?
All right. So I've got 2 dogs. Okay. In fact, my daughter's got 2 dogs. She loves her dogs. Okay?
What kind of dogs?
One is a golden retriever and the other is a beagle. Okay. And they're my daughter's dogs. She loves them and I love them in turn. So we spend a lot of time, me and my daughter, playing with our dogs. We also see a lot of Instagram memes on dogs because she's such a dog fan. She's just crazy about all kinds of dogs. So me and her spend a lot of time, just watching these cute little things about dogs together. So we spend a lot of time together like that. Other than that, I think I like to watch movies sometimes. And then maybe write an article for fun. Uday, is that acceptable?
Yeah, whatever makes you happy. You're a prolific author. You're not 1 or 2 articles. You're prolific. Amazing.
Yeah, I do enjoy writing it. Sometimes you just get into that mood and then it just comes so easy. You just you don't want to stop then. So I do enjoy doing that. Yeah.
No, you've been a huge contributor to ophthalmology. And so we obviously all benefit. Our patients benefit from your papers. That's fantastic. Now, in terms of movies, we were talking earlier about AI. Have you seen these new things now where the AI actually makes the whole movie?
Oh, yeah. You have these newer,
Unbelievable.
Unbelievable. It is really unbelievable because you cannot even make out that it's not a real person or a real dog or a real automobile or a real just a snowstorm that's happening. It's just all artificially generated, and that is beautiful and also scary a little bit because you wonder what is going to happen to all those animation artists whose livelihoods depend on what they do. All those actors, it's an entire industry, right, which is there. So it is also a little but I don't know. I think basically a way to think about it is when the wheel was first invented, somebody might have said, what will happen to all those people who used to actually walk by foot and carry something from here to there? Well, they then became the drivers. So
they'll be fine.
I'm sure the other people will find something else, which is also going to be very nice and motivating for them. And science keeps progressing, and everybody continues to do well. That's the really nice way to look at it, or the happy way to look at it.
Well, I think it's great. Plus, the nice part is it makes it more accessible to everyone. Absolutely. So I can think of an idea. I could write a whole movie script and have the AI just do it for me.
And you can also get the actor or the actress to say anything you want in any accent you want with any speed you want, right?
Right.
It's all
the same with doing a video here, doing a podcast, having it accessible by internet everywhere. It's just 20, 30 years ago, I couldn't have done this. I couldn't have a conversation, make a video with you and have thousands of people around the world see it. There's no way of doing it.
Completely, I agree. And I think the one other thing that internet has done is it's democratized everything, right? So everything has become accessible to everybody, which is really something that has kind of improved everyone's life. It's not just the rich or the wealthy who are getting everything, but everybody gets it, which is humongous, which is a big thing.
No, it's fantastic. It's brave new world. So I can't wait to see where all this goes, not only in these kind of topics, but even in ophthalmology. I think the new stuff that's coming is going to be amazing. The tough part is we all have to be good lifetime students because we got to keep learning because things will keep changing every year.
I agree with you. But I think, it's fun if you're in the field and you kind of, involved in the field. It's really fun to keep on going with it. Now, maybe something in retina I'm no longer as much interested in, some great things which are happening there, which really excites the retinal surgeon. I'm not that excited by it, but that's what it's all about, right? You get into narrower and narrower fields and you find more and more there. and you find that you've gone to microscopic and submicroscopic levels, and there's still so much more that's waiting to be discovered.
Right. Every year I learn more and more about less and less.
Absolutely.
I just do fewer types of surgeries.
And that's
right?
true.
Like I could do a pterygium surgery, but I don't want to do it. I want to just stick with, I like cataract surgery. I like cataractrefractive surgery. Let me just stick with that because it makes me so happy.
I agree with you. I completely agree with you.
And then, yeah, you get to the point where when you know so much about a topic, then you realize how little you actually know.
That's also true. That's also true. I know. But I think our field is fun. Our field, I'm always happy that I took ophthalmology because it's got so much to it. It's a high-tech field. It's at the helm of innovation all the time. There's always something happening that's exciting. There's
Right.
everything. There's physics, there's lasers, there's mechanics, and there's optics, and there's plain old surgery, and there's bloodless surgery. There's very elegant surgery.
Mhm.
It just makes it the perfect mix to be in.
And my favorite, happy patients, really happy.
Absolutely, I know. That's so good because you're giving them functional changes to their life.
Well, thank you so much for this podcast. I learned so much from you. Brilliant. I've never done a CARES procedure. Now I may have to study up on it and find
I
some
hope you
appropriate
start
patients
soon,
to help.
Uday.
But I will take your advice. But what a pleasure to learn from you. What a brilliant ophthalmologist. Thank you again for doing this.
Thank you there again. Thank you so much for inviting me here. I have been a lifelong fan of yours. One among your, I don't know, 67,000 followers. You have to be having more than 3/4 of ophthalmologists around the world following you. So congratulations to that. Congratulations, and thank you for everything you're doing for ophthalmology, for your teaching. It's amazing. I learned so much from all your CataractCoach.com videos. They are so good. And I have all my fellows coming and telling me, how they watch your videos and how they learn so much from that. So thanks for doing that, and thank you so much for inviting me to your show.
Oh, my pleasure. Make sure you tell your fellows that they got to subscribe to the podcast and listen to it, especially your podcast.
I
And
will.
listen them on it.
I will do that. Thank you, Uday.
And I want to remind our viewers and listeners, remember, we've got a new podcast every single Sunday. And of course, every day of the week, we got a new CataractCoach.com video. So until next time, I'll check you later.